So we, as you likely know, studied argatroban and eptifibatide as adjunctive therapies to thrombolysis in the setting of ischemic stroke. And all subjects received thrombolysis within 3 hours of symptom onset. And we designed the trial such that we could answer the question for both of these medications, which we're very pleased with in terms of getting to a definitive answer for these two drugs in one trial as opposed to two separate trials. We also designed the trial so that we would have at various points a look at the data to see what the likelihood of the drugs improving disability after stroke was. And so one of those stops was after 500 subjects enrolled. And what we found after looking at the data from the first 500 subjects was that the drugs were basically not effective in reducing disability after stroke.
It was originally designed to be 1,200 patients. And like Dr. Adeoye mentioned, there was pre-specified looks at the data to demonstrate whether or not it was futile to continue or whether there was already a benefit and it could stop early. Unfortunately, it stopped at 500 patients due to futility. We did not see any signal that continuing the trial to 1,200 patients would have any change. We didn't find any benefit of the medications. There is one finding that we were a little surprised about, and that is the arm that received argatroban tended to do worse than the other arms. And it may be for several different reasons, a couple of which those patients had more large vessel occlusions, so they had larger strokes, and they had more incidents of atrial fibrillation. And so we think that perhaps that could have something to do with it. But importantly, we did not find any safety from a hemorrhage perspective. That's the major concern, adding antithrombotic medications to a clot busting medication, that you could increase the rates of intracerebral hemorrhage, and we did not find that.
We will certainly look at the data more closely. We already have, we are presenting here at the ISC a look at the subjects who were IV thrombolysis only. We're looking at the subjects who were the LVO subjects. And we also then have to sort of go back to the drawing board a little bit to see what other options there are in terms of this approach of trying to enhance the performance of thrombolysis. And so we still have some thinking to do about how best to move forward in terms of investigating this area.